Good afternoon, guys. Today will be a short video on notching in TKR, the classification which is used for notching, and also what could happen if we notch too deep during taking a cut during a total knee replacement. So, what happens in TKR is first we take the distal femur or the tibial cut, followed by the anterior, the posterior cuts, and the chamfer cuts. So, what happens in posterior referencing is when we take the anterior cut of the femur, if we take the anterior cut too deep, let's say for example, there's two implant sizes, one is a bigger implant and one is a smaller implant. Suppose we do want to put a smaller implant, we will have to take a larger anterior femur cut. So when we take a larger anterior femur cut, suppose it violates the anterior cortex of the distal femur, such a thing is called notching. I have the definition here. So it's nothing but the violation of the anterior cortex of the distal femur during femoral preparation during the anterior cut for total knee replacement. So what is the classification? When we are taking the anterior cut, suppose we violate only the outer table of the anterior cortex of the femur, then it's grade 1. Grade 2 is violation of the outer and inner tables of the anterior cortex. The grade 3 is violation up to 25% of the medullary canal, and grade 4 is violation up to 50% of the medullary canal. So in other classifications, grade 2 is also said when there's a 3 mm violation of the outer cortex. So it's either 3 mm violation of the outer cortex, or in this classification violation of inner table and outer table as well. So as you can see, when we talk about 25% and 50%, what we mean is from the anterior cortex to the center of the medullary canal 25% of the way, and from the anterior cortex to the center of the medullary canal 50% of the way, not 50% of the entire diameter of the medullary canal. So as you can see here, this will be 25%, 50%, 25% of the way to the center of the medullary canal. So you can see this is a good TKR where there's no notching at all. The outer and the inner cortex are maintained. This is an example where the outer cortex is disrupted, but you can see the inner cortex is still faintly intact. Here you can see the outer cortex is disrupted and the inner cortex is still intact. So this is an example of grade 1 notching. What notching grade do you think this is? So you can see the outer cortex is disrupted, the inner cortex is also disrupted, and it's going into the medullary canal. So it's greater than a grade 2 notching because the inner cortex is also disrupted. And you can see roughly it's between grade 2 and 3, it's most likely grade 3 notching of the distal femur. So what happens when we notch, especially with grade 3 and 4, which are really dangerous? Sometimes what happens is if the patient even has a trivial fall and there's not an adequate time post TKR between protecting mobilization and letting them mobilize freely, sometimes a supracondylar fracture of the femur can occur as a dreaded complication. So as far as possible, let us avoid notching while doing a TKR. Grade 1 and 2 is still okay. The incidences of notching with grade 1 and 2 is less, but grade 3 and 4, the incidence of notching grows up. The incidence of supracondylar fractures post notching goes up drastically. Thank you.